this Awareness Week webinar, where the focus today is on UK CUP research. My name is John Simons, and I am the founding director of the CUP Foundation, Joe's Friends. The charity was established some 15 years ago following the death of my wife, Joe, and as it happens, 2 years before that, my eldest sister also died from CUP. Today, in 2021, it comes as a surprise to many people that CUP can exist and that it is a cancer affecting some 9,000 people in the UK every year. And this accounts for some 2 to 3% of all new cancer cases. The unknown element of a CUP diagnosis, more specifically a carcinoma of unknown primary diagnosis, is particularly frustrating and frightening for patients, their families, and friends. Initial clinical presentations are usually non-specific, and then patients are often left bewildered with an unknown cancer designation. It seems incredible in this scientific age that we do not understand the biology of CUP, other than the generally accepted hypothesis that the cancer spreads very early and unpredictably from its starting point in the body, where the primary is unusually small. This makes it a challenging diagnosis for the pathologist because the cells have lost their unique features in the cancer spread, and for the treating oncologist, as well as for the patient. Before handing you over to Dr. Natalie Cook, who will chair our expert panel today, I want to show you 2 slides. The first slide shows an encouraging decline in CUP over 2 decades. If you're not familiar with these statistics, you need to know that the data collection and publication always lags by 3 or 4 years. But in 2021, CUP is the 15th commonest cancer in the UK. 10 years ago, it was the 7th commonest. So in cancer terms, this is a very significant decline. But it still remains the 5th highest cause of cancer death in the UK. This week, I am attending the memorial service for my brother-in-law, who died from CUP during the pandemic. The second slide shows the sea change in CUP in the last 20 years. Note the pivot point of 2010 with the publication of the NICE guideline. From that point, CUP was no longer a failure of diagnosis, but a diagnosis in its own right, with patients being put on a recognized pathway. Expertise in diagnosis and management has gradually increased, and research has risen exponentially in the UK. The solution, in inverted commas, to the problem shown in the bottom of the slide has not been reached, but it is getting ever closer thanks to exciting research carried out by researchers throughout the world. And we have some outstanding ones in the UK, some of whom will tell you about their research when I hand over to Natalie.
Thank you, John.
Dr. Natalie Cook, amongst other many appointments and roles, is a consultant medical oncologist at the Christie in Manchester and chief investigator for the recently launched CUP-COMP trial, comparing the impact of genomic sequencing approaches in tissue and blood in patients with CUP at 7 NHS sites across the UK. If I may, I will now hand over to you, Natalie.
Thank you, John. Apologies, I came in a bit early then. So it's my great pleasure today to kind of chair this session looking at an update on the CUP initiatives and research within the UK. particularly after the fantastic seminar yesterday on the research initiatives in Australia. I just want to mention that the aim of this whole week is to bring together researchers from around the world via these webinars and the website worldcupawareness.org. We want to build this website as a connection hub for sharing ideas, for sparking projects. So if anyone in the audience has got a project and they want to get in touch, please feel free via this website. The charities that have initiated this project are looking also for sponsorship opportunities in CUP, and they're interested in how we can advocate the needs for clinicians and patients. So please do share your thoughts on this website. And I want to thank the charities for bringing us all together for these webinars. In the interest of time today, I think we'll have a question and answer session at the very end of all the talks, but please do submit your questions via the chat function and we'll look at them and answer them towards the end of the seminar. So without any further delay, I'd like to introduce Dr. Kai-Keen Hsu, who's a medical oncology consultant at University College London Hospitals. He treats a number of different cancers, including CUP, and he's the UCL lead for CUP and acute oncology. He's got a number of research interests, including immunotherapy for GI malignancies and CUP, and he's the lead UK investigator for the CAPISCO trial. Kai-Keen, over to you.
Thanks very much, Natalie, and to John and to Tanya and the whole team. And for the interest of time, I'm going to go straight, hopefully, into my slides. So hopefully this will work. Okay, hopefully you can see my slides. I will move straight on, but apart from being the lead UK investigator for the CAPISCO, I'm the chair of the NCI Living with and Beyond Cancer MEO CUP workstream, which I'll touch on today. So as John has said, is that, there's been a sea change in terms of trying to diagnose cancer in primary or exclude cancer in primary. And there's been ESMO guidance for a while, and also there's NCN ASCO guidance too. So I won't really go into this because this is something that you can read on the internet, really. But what I would say is that, yes, our aim is to actually make the unknown known, and actually my other aims maybe is to eventually completely eliminate the diagnosis of CUP. But even within the CUP spectrum, there's a group of patients who are good prognosis CUP, usually lymph node predominant disease, squamous cell cancers, neuroendocrine, and single sites of disease. But within the non-specific subset of CUP, which is the poor prognosis, we think maybe bone disease, liver disease, poor performance status, high LDH, high CRP, which I know some of the speakers will talk about later, there's still a poor prognosis and a good prognosis CUP. And as I said, one of the things actually John touched on is, although NICE guidance was extremely good in kind of making sure that we knew what was an MUO versus a provisional CUP and a true CUP, is at the time it wasn't designated that gene expression profiling was a kind of requirement, where I think we are now trying to change that view as we do a lot of kind of genetic profiling for all other common cancers. And remember, what I tell my trainees and all my staff is that a cancer ovarian primary presentation is more likely to be a common cancer presenting in an unusual way rather than uncommon cancer presenting in a common way. And so NCN even have not, although in America they often like to do lots of profiling, they haven't said that you absolutely have to do it, but we should use it in a judicious way. Having said that, Tony Greco, one of the doyens of CUP in America, has said really, if we're doing the right thing for our patients, we should be using some kind of genomic profiling or molecular classifier to at least help the treatment of the patient, even if we may not yet find the primary. And this is a really nice slide from John, which I unashamedly borrow, but he mentioned this is that, since the whole genome project over 10 years ago, and now a lot of patients come to us and say, how come we cannot find where my cancer is coming from? And you even come to oncologists. I've gone through a long pathway of non-diagnosis or diagnosis tests, and I still can't find where this is from. Then the natural things that any patient with advanced cancer will ask is, how long will I live? The uncertainty of all this, the double whammy of not knowing even where the cancer is from. How urgent is the treatment? What should I tell my friends and family? And actually, one of the main things now is their trial. And hopefully we'll show you over the next few hours that there are many studies and trials for cancer in primary patients. So I don't really want to talk about my own research, because I think there's some really exciting research coming through from the young investigators that Nat and I work with. But I do chair this group, okay, which has now been part of a CSG within the UK. And this is trying to separate cancer in primary from acute oncology, which I also run at UCH. And I do think that it's really important to separate that, because acute oncology can encompass a number of acute conditions, either related or not related to cancer, and not necessarily the first presentation of an unknown primary. So we're trying to move the whole field forward and say, okay, that's fine. But in terms of our patients who we think are going to be living with CUP, we've got to do much more for those patients in every part of their treatment and their management and their support. So I chair this group with Sally Clive in Edinburgh, Claire Mitchell at the Christie Manchester, and Sonali Dasgupta in Wales. We have a pathologist, a radiologist, it's a bit like an MDT, a CUP nurse consultant, a research methodologist, and very importantly, we have patient representatives, really important here, including John. And we have a trainee representative, Alicia, who's also going to give a good talk. And these are objectives, okay? So John touched on it, that we can find the primary using molecular profiling. At that point, what are we trying to do? We're converting them into a primarily specific therapy, which would be more effective than generic platinum-based chemotherapy. And therefore, part of our work is to how do we get these patients to have timely and appropriate investigations? You know, and that is touching into acute oncology management as well. But we're now trying to say, well, can we use tissue of origin tests, novel diagnostics, and part of that is, of course, from a patient perspective, quality of life, PROMs, PREMs, and patient-directed things, which I will talk about in 1 second. Then for most patients, they say, okay, well, I don't know where the primary is. I don't know what my prognosis on average is, but tell me that you can treat me, and maybe not just with, you know, a broad spectrum chemotherapy. And that's where we have to say, okay, we've done a number of tests, we've done some profiling, we've got to use CUP MDTs. And that's a real strength in the UK over the past few years, that like most district general hospitals and tertiary centers have a CUP specific CUP MDT that sits outside of all the other lung, breast, GI MDTs. And now we're trying to push, as Natty will talk about, and her team, about the kind of national genomic MDTs, not just for all cancers, but specific for rare cancers like CUP. And in that, we have the kind of thinking about novel biomarkers, trials for patients. We've got the thinking about trials for the patients who don't fit a trial. And again, really important to get those patient quality of life measures. And therefore, by doing that target, we prove that even in a CUP patient, that target therapy is feasible. And we have a number of, you know, already other target agents we use in other common cancers where we think it is kind of agnostic, but it's also slightly contextual. So we have to realize that CUP is also a very heterogeneous disease. It could be a number of occult primaries that we're trying to treat, but may be driven by a unique target. And of course, what we really want is to support the clinical studies. As Natty says, you know, we're really supportive of that. Collaborative, of course, within the UK, as you'll see, but we really are trying to collaborate outside of the UK too. And by doing studies and trials, it's the optimal way to test a treatment strategy. And one of the things we also about is that even if you don't have one right now, biobanking, you know, or true CUPs, even if there's not an active study yet, is also incredibly valuable. So again, I'm sure we'll be talking about that during this whole meeting. And I guess, without being facetious, the CUP holy grail is to find a tissue of origin, okay? And we have tried this a few times, both from an academic point of view, commercialized with not much success. So we tried to look at miRNA profiling. It didn't really work, but there's some really interesting work. And I know Manel Estella is talking this week as well about his kind of epigenetic profiling, kind of methylation profiling to try and find, you know, the tissue of origin. And that kind of makes sense, right? Because these poorly differentiated cancers may have silencing mechanisms that we cannot, that's why we can't detect them on standard IHC. And we look for the methylation of certain genes to find the primary, really exciting things. Hang on. Not sure. Okay, yeah. So if we kind of step back, that we haven't yet found the kind of tissue of origin test, the most things that most patients want is, okay, look, you don't know where it is, but what can you do to try and help me have more than just chemotherapy, platinum-based chemotherapy? And nowadays, there's a number of academic as well as commercial tests to profile our tumors, okay, both small panels and larger panels. So The possibility of primary tumor is an access issue for sure, but it is possible. So that's relatively easy to do. Whether you find an alteration is another thing. And more importantly, is there a treatment that is matched to the alteration? And even harder is, can we access that treatment? Remember, this is in the context of a cancer unknown primary patient where there may be limited studies and trials. And of course, the big thing is, will I respond to the treatment? And that's an unknown quantity. But really, at least we could give a go at it. That would be really good. And we've got to understand the extra stress and expectations that we all have, but in particularly from the patients and their friends and loved ones. And so this is just a quick example. This is a patient who I treated when I was a registrar and then as a consultant, who was an unusual cut patient. He presented with an unknown primary with a sternal mass and tiny lung nodules. And because I'm a GI oncologist, we gave him a platinum drug, FOLFOX. He was an unusual patient for many ways. He had no toxicities from FOLFOX. And every time we gave it, he responded. So we were kind of happy. He was happy. He did keep on asking me over the kind of 7 years that we looked after him, will we ever find my primary? And we did try. Unfortunately, at the end, he developed brain metastases, and we had access to a liquid biopsy test called Guardant 360. And interestingly, this did show an FGFR amplification. And we were trying to get him a compassionate access to this, to one of these drugs, but he had to have control of his brain metastases, and he never recovered from the whole brain radiotherapy. So he never got to that targeted treatment. And I always think about this case because I say, well, you know, he did really well for someone who's lived for more than 5 years with a true unknown primary, I think. But whatever happened if we had done that profiling a lot earlier in the pathway? And so the other thing was that he lived with his mother, and the mother actually refused to put him into something called the PEACE trial, which I'll talk about briefly, and I'm sure Natalie will as well. And this is interesting about, you know, patient decision aids, about how can we help? And John, with his team, even before I started as a oncologist, has created these patient decision aids, which I think are unique. In fact, I think they're even better than some of the things I would even talk to some of my colorectal patients or pancreas patients or cholangio patients. So on the CUPJO website, there is actually a section which has got the patient decision aids, which anyone can actually look at. And this is one of the things that it asks our patients and their relatives about, you know, what are the options available, what have been offered, and how important is it for you to have? So, for example, how much is it important for me to have as much information on my cancer, even if it costs me money? No, I want to start treatment as quickly as possible. No, I don't want to spend much time on kind of really novel treatments. I just want to get on with some things. And that's really interesting. So we've never really tested that. So we're also within our NCI Club group going to test actually how useful this is for our users, not only the patients and their loved ones, but also the oncologists and the surgeons, anyone else who can touch base. So we are doing this decision-making kind of program to see how useful these patient decision aids are. And I think that's a really important thing because we kind of ignore that a lot. Now, in terms of trials, and we've mentioned this, I am the UK chief investigator for the CABISCO trial, which is a really unique study. And I know that this week you're going to have a whole session on the CABISCO trial, but I think this really shows what happens when people really get together. So the origins of this study were there were lots of ideas about how to kind of test kind of novel therapies in CUP patients, but it would have been potentially a mishmash of many phase 1-2 single-arm studies. But Roche, Hoffman and Roche, decided to get lots of minds together and bang it together and do this fantastic, I think, randomized phase 2 trial of kind of induction-based platinum chemotherapy with molecular profiling up front, and then randomization in a very generous 3-to-1 way to novel therapies, a number of alterations, which I won't go into so much, but it includes immunotherapy. And really importantly, it's a platform study in a way with baskets and also adaptive. So there's all the things that we like in novel trial design, and it moves with the science. So we started actually adding arms even when the trial was live. And so now we have an NTRK ROS arm, and just recently we have got an FGFR and IDH1 arm. So it's a really mobile trial, and we can talk about it later, but I think it's a really good commercial study, but with a lot of academic interest beyond that. And although the primary endpoints are the standard ones about progression-free survival and overall survival, there's a lot of translational work behind all of this, which I'm sure the CABISCO team will actually mention later this week. But I think we have to kind of support also our investigator-led academic studies, and our good colleague, Dr. Harpreet Wasan, who ran the CUP1 trial many years ago, has now got this investigator-initiated study of immunotherapy in CUP patients. Okay, so we know based on this study, this kind of retrospective analysis by Yarchan in the New England Journal of Medicine, that probably the response rate to immunotherapy is based around mutation burden. And we think that a lot of our CUP patients may have highly mutated cancers, okay? So it kind of makes sense that we should try it. And I think this is a really interesting study which has done extremely well in recruiting patients. It's had a first cohort of patients who are chemorefractory, and then we're moving into the frontline setting. And you may know that at ESMO in the past year, there's a Japanese study called NevoCup, which is doing a very similar thing with really good benefits. So maybe immunotherapy may be a rather good baseline therapy with or without chemotherapy for our CUP patients if they have no other known alterations. And then let's just go into a little more science, which I'm really interested in because I work with Charlie Swanton and Mehmet Harjani with the Peace team and the CUP team within Peace. And this is the general idea, is that actually, do we think there's a unique CUP signature, okay, not just the kind of involuted primary, but actually would allow us to go backwards and work out what really is driving these CUPs across the board. All right, so this idea that you have a driver mutations and then you have distant relapses with lots of clonal changes. So the Peace study is a really interesting study. Actually, it was initially set up, based on lung cancer patients and colorectal cancer patients, a post-mortem study. So this is interesting to actually consent someone for, if and when you pass away, would you be okay that we do a kind of an academic post-mortem or tissue collection? And actually, a lot of our CUP patients, you believe it or not, are not that unhappy about this, because either they or their loved ones have, even in the past, have said, look, thanks for treating my mother, father, brother, but can you still not help us find out and give us peace of mind of what's going on? So it's actually not so difficult to recruit people into the Peace study who have got a CUP diagnosis. And so my last couple of slides show that with Peter Van Loo and my team, we have actually put our first kind of CUP patient into this program, and we'll publish it later. But, I think it's really interesting if we can try and untangle all these kind of from, doing a post-mortem of all the metastatic sites, we can actually work out maybe the etiology history of CUP, track the spread, and then actually find the site of origin. Now, of course, this is in a post-mortem setting, but everything will feed back into real life. So I really think that this is an important way of going all the way from what we support our kind of patient-centered projects like the PDA project, all the way to really trying to disentangle high-level molecular biology. So this is my last slide. That, as John says, CUP biology is still not that well understood, but I think there's a lot of interest now, and it's a really great kind of field to get into. Lots of opportunities for young researchers to kind of get into the field of scientific research. And of course, in order to do this, because it is essentially a rare cancer, multidisciplinary and international collaboration is absolutely critical. And on top of all of that, again, I have to thank Tanya and John and everyone also in Australia have done a lot of things. Patient involvement and feedback cannot be underestimated. So thank you very much for listening.
Great. Thank you for that excellent talk, Kai Keane. And in the interest of time, and as I mentioned, we'll be taking questions at the end. So if you do want to submit them via the chat function, please feel free to do so, and we'll address them all at the end. So I'm now going to move on to the first of three, next generation CUP researchers, which is fantastic to see. And it's great that they can all join us today. The first of which is Dr. Alicia Marie Conway, who I know very well. She is an academic medical oncology trainee in Manchester, and she's currently a research fellow undertaking a PhD at the Cancer Research UK Manchester Institute Cancer Biomarker Centre. And her PhD is solely focused on CUP and also looking at liquid biopsies. And I believe she's going to talk to us about this today. So over to you, Alicia.
Thank you, Natalie. Yes, I'm delighted to speak to you all today about the fantastic translational work that we're doing at Manchester. And as Natalie said, she's my clinical supervisor, and it's a collaboration between the Christie Hospital and the Cancer Biomarker Centre at CRUK Manchester Institute. So I'm just going to give you a brief overview of the types of research that we've been developing over the last few years in CUP. So just to give you context, in the UK, as has been mentioned, we have NICE guidelines that first define the metastatic presentation of an unknown primary as the malignancy of unknown origin. And this is prior to any initial investigations, and patients who have initial investigations that don't reveal an obvious primary, then get a diagnosis of provisional CUP. Those patients go onto the CUP pathway and are discussed at a CUP MDT. So further investigations usually lead to a primary tumour diagnosis for most patients, but those without a primary tumour diagnosis fall into this confirmed CUP cohort. And as Kai Keane has mentioned, these patients can have a favourable subtype or unfavourable subtype of CUP. And we know that the favourable subtype patients do a lot better. They have access to molecular profiling, novel therapeutics, and tend to respond to therapies similar to other metastatic tumour types. Unfortunately, the majority of patients fall into this unfavourable subset, and those patients can be offered palliative chemotherapy or best supportive care. And we treat these group of patients as a homogeneous group, despite the fact that we know that there's clinical, pathological, and molecular heterogeneity within this group. So our research really focuses on trying to look for clinical pathological features, novel biomarkers, and potentially tissue of origin predictions that may be able to subtype these patients into metastatic subtypes that have better therapy options, including immunotherapy and targeted therapy. And one of those subtypes is intrahepatic cholangiocarcinoma, a rare type of biliary cancer. So the three main threads of the work we do in Manchester is to find more favourable subtypes, overcome some of the limitations we have with tumour tissue and tumour biopsy, and stratify patients to better therapy. So one of the favourable subtypes we're focusing on is this rare entity intrahepatic cholangiocarcinoma, or ICCA. So we have done a retrospective case series of nearly 230 patients that were referred with provisional CUP to the Christie in a 3-year period. And we split them into patients that either had liver involvement or no liver involvement. And all those patients that had liver involvement of metastatic cancer had radiological review independently by a hepatobiliary specialist oncologist and radiologist. And they were looking for the typical radiological appearances of intrahepatic cholangiocarcinoma, so things like capsular retraction or dominant liver lesions, versus non-ICCA, which is multiple small metastatic deposits. Those that had non-ICCA may have gone on to have a primary tumour diagnosis or confirmed CUP at the end of their pathway. So when we look at this whole case series, we see 22% of patients presented with provisional CUP actually ended up with a primary tumour diagnosis at the end of this pathway. Of those with confirmed CUP, 24 of them we identified as fitting the radiological criteria of having intrahepatic cholangiocarcinoma. So that's 11% of our whole cohort and up to nearly a third of all patients presenting with liver involvement. So this is a really important group of patients that are probably overrepresented in CUP cohorts because there's a lack of biomarkers that help us make the diagnosis. And the reason it's important is that newer targeted therapies are approved or in late phase trials really might change the treatment outcomes for these patients. So we think this evidence supports molecular profiling in these patients to aid diagnosis and direct therapy. But as we found in this study, there's a real challenge of using tissue for molecular profiling. So we retrospectively tried to look for to perform that molecular profiling in these patients, and a lot of patients had no tissue or limited tissue for any diagnostics. So there's a need for better biomarkers, and we need to overcome the limitations of tissue. And that's the main focus of my PhD. So I have the privilege of working in a world-leading laboratory that specialises in liquid biopsy. So I predominantly work in blood, and we know in cancer patients, blood, there are rare circulating tumour cells that we can isolate and molecular profile, and also circulating free DNA, of which a proportion is from the tumour. So we can isolate, extract this information and perform molecular profiling, and we know that these samples reflect that of the tumour. So the last 4 years, we've been developing a multi-omics profiling assay that enables us to profile cfDNA from CUP patients. From one blood draw, we can do mutation profiling, copy number change, and methylation profiling. And our current work is looking at predictive biomarkers and the ability to predict tissue of origin from this blood test. And I'm in my final year, and the results are looking really exciting. And I hope in the next few months we'll be able to release some of the data on a small cohort of CUP patients that really might change their the future of how we diagnose and treat CUP patients. So finally, I just want to touch on the third arm of our work in Manchester, and that's stratifying patients to better therapies. So as mentioned by Kai Keane, Natalie leads the CUP-COMP trial, which aims to perform molecular profiling in tissue and blood to help in the diagnosis and treatment stratification of patients with CUP. And it's a real collaborative approach, joining together commercial entities, academia and the NHS. It's open across 7 UK sites, and we hope to recruit up to 150 patients by September next year. All patients will have real-time tissue and blood molecular profiling, and that will be fed into a virtual CUP molecular tumour board with the view to making clinical decisions in real time based on this. And this is actually a really important cohort of patients for data mining. We'll have a lovely data set to analyse, and also building a collaborative network of CUP researchers to take forward. So just to talk about the last 4 years, we've really built up the CUP research in Manchester and continue to expand it. And we hope we couldn't do any of it without all of the funders and supporters, especially Joe's Foundation. So I just want to finish by acknowledging all the people that have helped in all of this work. So there's too many people to mention, but all of our collaborators, all of the funders, the patients, their families, and everyone at the Cancer Biomarker Centre and the Christie that support this work. Thank you.
Great. Thank you so much, Alicia, for another fantastic presentation. Obviously, I might be a little bit biased, but great work there. So again, please feel free to ask questions. We will address them all at the end. And without any further ado, I'll move on to our next investigator. So this is Dr. Mark Lithgow, who is an academic clinical fellow at Imperial College London. He's a medical oncologist and also a pharmacist, I believe. He's currently undertaking a PhD under Dr. Krell, exploring the cancer microbiome and looking at all biotherapeutics as novel anti-cancer agents. And he works very closely with Dr. Krell and his team, trying to use new drugs in patients with solid tumours. So I'll be really excited to hear this talk, Mark. Over to you.
Great, thank you, Natalie. So many thanks for asking me here today to discuss my project on analysing the intratumoral microbiome in cancer of unknown primary, exploring diagnostic and biomarker utility. So I thought I'd first to start with a little bit of background. So the microbiome was really first described by Antony von Leeuwenhoek, the father of microbiology, in the 17th century. After his famous description of animalcules, he turned his attention to his own bodily fluids, and of note described the first pathogen during a personal bout of difficult diarrhea, which we now know as Giardia lombardia. However, it really wasn't until the 1950s and the pioneering work of René Dubois at the Rockefeller Institute in germ-free animals that the link was firmly validated. However, human microbiome research really didn't become an established field until the transformative work of Carl Woese and Robert Pace developed the technique of phylogenetic taxonomy of the 16S ribosomal RNA subunit, and incidentally discovered a new domain of life, archaea, at the same time, but didn't win a Nobel Prize. We now know today that the microbiome plays a really significant role in both health and disease, from birth to death. Looking just at the bacterial component of the microbiome, we each harbour 100 trillion bacteria with over 1,000 different species, and they outnumber endogenous cells by a factor of around 10. So there's been increasing recognition of the significant role that the microbiome plays in cancer pathophysiology, including tumorigenesis and development, also evolution, progression, and metastasis. And much more recently, we know that it significantly can impact treatment efficacy, from cytotoxic chemotherapy and the effects it can have on cytotoxic chemotherapy drugs such as gemcitabine, to more recently to immunotherapy and immune checkpoint inhibitors like pembrolizumab and nivolumab. To the very much more recent research a couple of months ago, which used fecal microbiota transplant to transform treatment responses to immunotherapy in refractory melanoma patients. We now know the microbiome has the potential to affect all the key hallmarks of cancer, and is one of the reasons why it's such an intriguing target, and is also one of the reasons why I'm doing a PhD in this area. So moving on to the intratumoral microbiome, this has really been receiving increased attention over the past 2 years. And this was a front cover from Science last year. and provided the first comprehensive assessment of the intratumoral microbiome performed by our collaborators at the Weizmann Institute in Israel. Refinement of techniques to identify and analyse tumour samples has allowed microbes present within the microtumour environment to be isolated and characterised. We now know that bacteria are found intratumorally across many cancer subtypes, including melanoma, lung cancer, ovarian, glioblastoma multiforme, pancreas, and breast. This is a technique that's undergoing constant refinement, and we're hopeful that this list is likely to grow significantly over the next sort of 2 to 3 years. If we look at the work in human pancreatic ductal adenocarcinoma, studies have shown that 76% of tumours contain intratumoral bacteria. Overall, we can see this is very different from healthy pancreatic tissue, which contain relatively very low levels of bacteria. And we believe this is due to a distortion of the normal architecture caused by cancer cells, which allows bacteria to grow and thrive in this ecological niche. When the bacterial component of pancreatic ductal adenocarcinoma is characterised, the majority of samples contain very high levels of proteobacteria. The bacteria isolated show similarity to the normal healthy human duodenal microbiome. So really the next question is, are these bacteria innocent bystanders that are taking advantage of the biological niche, or are they actually impacting the cancer pathogenesis? We now know that bacteria within the tumour microenvironment can really affect the potency of chemotherapy. In this example, proteobacteria are able to metabolize the cytotoxic chemotherapy drug gemcitabine and reduce the anti-cancer efficacy in pancreatic ductal adenocarcinoma. There have also been further studies which have shown similar effects for other cytotoxic chemotherapies, such as cyclophosphamide and irinotecan. Within the microtumour environment, bacteria occur mainly intracellularly, hence can be very difficult to isolate and analyse, and the techniques for this have only really been developed over the past 2 years. On analysis, we know that bacteria primarily occur within the tumour cells, and quite interestingly, they also occur within immune cells as well. However, once we're able to isolate the bacteria and extract them, we can actually grow them under the right conditions in the laboratory. We can then go beyond our 16S ribosomal RNA analysis and do much more in-depth profiling, and we can actually categorise bacterial subspecies by shotgun metagenomics. This technique has now been refined enough so that we can identify distinct microbiome compositions in different tumour subtypes. This slide really shows an example of the microbiome signatures that have been identified for pancreas, lung, glioblastoma, ovarian, breast, melanoma, and colon. However, as our library expands, we are constantly adding to this and refining this. Overall, it's been consistently shown that intratumoral microbiome is closely related to the normal microbiome of adjacent epithelial tissues. Really, it's this observation which got myself and our collaborators at the Weizmann Institute interested in the cancer of unknown primary and using the intratumoral signature diagnostically. So cancers of unknown primary account for 3 to 5% of all cancers, and treatment choices are really determined very much by the likely tissue of origin. As Kaiki mentioned, current IHC techniques can reliably identify the tissue of origin in around sort of 60% of cases. Potentially combining with genomic information, we can increase this to maybe sort of 70 or 80%. Multiple different techniques are under sort of evaluation, including gene microarrays, microRNA, DNA methylation analysis, to try and really improve this identification. However, they've only really been met with limited success. For our study, we really wanted to explore the intratumoral microbiome in cup samples to see if we can use this to help identify the tissue of origin. We'll explore this both in isolation and in combination with existing techniques to try and improve both the sensitivity and specificity. Furthermore, we hope to use this to see if this technique can be used to predict therapy outcomes, as we know that the intratumoral microbiome can affect the effectiveness of many anti-cancer drugs. Also, this is hopefully going to feed into other microbiome work we are doing, potentially looking at utility as a biomarker, and hopefully one day looking at whether or not we can potentially modulate the cancer microbiome to improve therapy responses. Analysis is relatively straightforward, and we can use fixed formalin paraffin embedded samples, and we roughly require around about sort of a minimum of 8 samples with paraffin controls. We can extract the DNA and RNA and compare these against our pre-existing library to identify one, the microbiome signature, which may be unique, however, may also indicate a tissue of origin, and also secondly, to see if this can ascertain the likely site of origin based on bioinformatic analysis. We will then combine this with IHC and genomic information to see if this improves the specificity and sensitivity. Finally, we hope to correlate this with tissue response to see if this can be predicted based on the microbiome signature. Now, typically when I do this talk, the most frequent question I get asked is how we deal with contamination. And this is a real significant problem in any microbiome related research, but it's particularly significant when analysing intratumoral microbiome due to the low biomass associated with this. However, we're very confident that we've developed an optimised analysis workstream and numerous negative controls to ensure the validity results. By performing 16S RNA analysis on plain paraffin samples, this will allow recognition of the likely bacterial contaminants used during the sample preparation. My colleague that helps with the analysis has perfected this technique so much that he can analyse 5 samples blinded and can actually predict which centre has contributed to the sample, and so far has 100% accuracy. So we really think this is an exciting project sort of moving forward. And the hope is really to develop this pilot data into a much more larger prospective study. And as always, we're actively seeking any potential collaborators. So if anybody watching this would like to get in touch, please feel free to. Just to close, I would really like to thank our key collaborators, Dr. Ravid Straussman from the Weizmann Institute in Israel, and also our funders, which is Cancer of Unknown Primary Foundation, Joe Strand, and John himself. And if anyone has any questions, I'd be more than happy to answer them. Many thanks.
Great, thanks, Mark, for that fantastic talk. So, I mean, obviously everyone focuses a lot on genomics, but maybe we should start focusing on the microbiome a little bit more from what you've just been saying. So, so thank you. And again, any questions, please feel free to submit them via the chat function, and we'll address them at the end. Right, on to our final speaker, Dr. Mark Stairs. He is a specialist registrar in medical oncology and is currently undertaking research activity as a clinical research fellow at the Edinburgh Cancer Research Centre at the University of Edinburgh. His main research focus is on bringing together detailed clinical and molecular profiling data to improve management pathways, particularly in patients with CUP and also renal cell carcinoma. So over to you, Mark.
Oh, hi there. Hopefully you can all see my slides. Thank you very much for everybody for having me today. And I hope to speak to you about something slightly different from the work we've been doing in Edinburgh. As Natalie said, I'm a medical oncologist with a keen research interest in cancer informatics, bringing together particularly medical data, but also real world clinical data. And I've been doing that within the Edinburgh CUP service for the last couple of years. And just as a bit of background to us here in Edinburgh, we're a large cancer centre covering a population of 1.5 million across the southeast and towards the west of Scotland. And there's been an established CUP service here in Edinburgh since the NICE guidelines that John alluded to earlier were put forward in 2010, which follows very much the NICE guidelines in the way in which we manage patients and get them through the pathway. It's increased in its use over the last few years, and over the last 2 or 3 years, it's seen about 170 referrals per year. Not per se everybody with CUP, but we take patients who've got a diagnosis of malignancy of undefined primary origin, which I know is a term that's been mentioned a few times throughout these talks. And just for those not from the UK and less familiar with that, that's patients who've got a radiological finding of a metastatic malignancy without an obvious primary source. And we've been very lucky here in the CUP service that since 2010, the team have been collecting real world clinical data and outcomes. And we now have an Edinburgh Cancer Centre CUP database which contains information for over 1,400 patients, making it one of the largest of its types in the world. So this is a flow through what happens to our patients from a recent publication. So patients get referred to the team with a radiological suspicion of metastatic malignancy without an obvious primary site. Some patients are not fit or too unwell for investigations or treatment, and those patients retain this diagnosis of MUO and are often treated with best supportive care. Some people undergo investigations and are found to have a cancer unknown primary, but are not well enough to come and see us in the clinic, and those patients in the UK are said to have provisional cancer unknown primary. The largest majority, about a third of patients that are referred to the service, we actually find a primary, and after some basic investigations, including imaging and IHC analysis. And it's important that all these patients down here will have had some kind of tissue biopsy. But as you can see, the patients who are most important for today's talk are about the quarter of patients that we see who have a confirmed CUP. So these are patients who have undergone comprehensive investigation, including a tissue biopsy, and have also seen us in the CUP clinic. And I suppose our setup is a little different to some of the teams that have spoken today, in that we see patients from across the whole gambit of MUO, from those who are clearly not fit for further investigations at the beginning to those who are very fit and would be suitable for clinical trials. We've done a recent analysis of our patients who presented to the service, and we've looked at the histological subgroups of CUP. We're very lucky to have a well-established MDT in CUP with a very good pathology team who do extensive IHC analysis, and we break down our CUP subgroups based on this. And in finding, as has been found in some of the guidelines, particularly ESMO guidelines, about 20 to 25% of our patients have a favourable prognosis CUP based on their clinico-pathological characteristics, including those patients with a colorectal phenotype, women with a serous papillary ovarian type phenotype, etc. What we do see in our patients, though, is that overall survival is pretty poor in all the patients who are referred to our team. So amongst the whole cohort, the average survival is only a matter of 9 months. Really important, we do have a group of patients, about 7% of patients, who have a non-cancer diagnosis after lots of investigations, and those patients have favourable prognosis. But it's these patients with the confirmed CUP who I'm really going to speak about today in terms of the rest of my presentation and what we do with our real-world clinical data. So I think, as this year and the team have already spoken about, we do differentiate between poor prognosis and favourable prognosis CUP based on clinico-pathological features. And what we find in our Edinburgh cohort is that our average survivals are much lower than we might have expected from patients who have seen in clinical trials. So typically, patients who have favourable prognosis CUP are often quoted survivals of 18 to 24 months. Our patients are only surviving for a fraction of that time. And our patients who have poor prognosis CUP are surviving for less time, up to 4 months on average. There's many reasons for this, but I think a particular reason is that our patients' population is a very unselected patient population. We see patients who would not necessarily be fit for a clinical trial. And although we've opened CUP Comp, I think and Capisco here in Edinburgh, I think it's telling that we have to be quite selective about the patients who've got into Capisco. What we try to do from all the patients who've been referred to us is try to harness the very detailed real-world clinical data we've got to define prognostic groups. And in particular, we try to do this using readily available, inexpensive, easily interpretable, routinely collected clinical details like blood tests, results of investigations such as their pathology and IHC, results of radiological investigations. And the main reason we've done this is twofold. The first is to try and identify patients who are likely to benefit from treatment. But perhaps more importantly for us, seeing these patients right from the very beginning of their journey, is to identify patients who are not likely to benefit from treatment and investigations, in order that we can help them make decision-making about further investigations and management, which can be intrusive and can cause lots of side effects and issues for patients going forward. One of the key things we've looked at over the last couple of years are biomarkers of systemic inflammation, and these can be any number of things. And in particular, we've looked at routine blood tests such as white cell count, neutrophil count, CRP, LDH, and albumin. And we're very lucky to have close contacts with the team in Glasgow who developed this modified Glasgow prognostic score, which is a marker of systemic inflammation based on CRP and albumin. And patients are graded from either having low levels of inflammation to very high levels of inflammation, from 0 to 1 on the score of 0, 1, and 2. And amongst all patients referred to the ECC CUP team of MUO, modified Glasgow prognostic score can stratify survival in a very meaningful way. And in fact, that we now request patients have a modified Glasgow prognostic score on their referral forms to see us when patients are referred to us to be seen in clinic. And generally, along with other things like the patient's performance status, their comorbidities, and having had an assessment of the patient, we can use the modified Glasgow prognostic score to provide further objective information to help these patients decide whether to pursue further investigations or management. More recently, what we're trying to do is apply some of these scores to the CUP population itself. So if we just take the 301 patients I mentioned with CUP before, we can stratify survival in these patients using these simple markers. But this rather crude method looking at all patients doesn't tell us everything, and we needed to think in terms of these poor and favourable prognosis groups. And what we can see is that MGPS stratifies survival regardless of the patient's favourable or poor prognostic clinico-pathological subgroup, and really identifies two groups, particularly within the poor prognosis classical group, a group that do have favourable prognosis, but also within these patients with favourable prognosis, a group that have poor prognosis, which is akin to the patients with a poor prognosis confirmed CUP. And we'd recommend using simple prognostic scores like this to help stratify patient treatment options, perhaps use it to select patients who are suitable for treatment, and then use their clinical pathological features for helping thinking about treatment, along with novel things such as biomarkers and molecular profiling. So it's a very brief rundown about what we've been doing, but what next? Well, the Edinburgh Cancer Centre CUP database continues to grow. We have approaching 250,000 data entry points within it already, and there's lots of work to be done within that. We're trying to expand that to our national cohort, and I'd love it if anybody listening would like to be involved in this and to have some of our data dictionaries that are available online. I can direct you that way. The database has also just recently been inputted into the Health Foundation iQual PPC study, which is a national study in Scotland, looking at improving the value and care for people with poor prognosis cancers. And a lot like what one of our other presenters have spoken about today, we have a biosample resource. So we now routinely collect biosamples from all our patients, and we do undertake some molecular profiling studies, and hopefully with further collaborations in the future as well. Finally, we've been looking at more novel prognostic scores. There have been a number of them out there in the past. iScoop for one, which I think Hakeem alluded to earlier on one of his slides. We've developed some new scores here. The Scottish Inflammatory Prognostic Score is something we've developed in our immunotherapy cohorts, which looks promising in our CUP patients. We've been looking at histopathological markers and radiological markers, and we've been doing that in collaboration with experts in computational biology and informatics, who are able to use machine learning to really dig into the data that we've got to try and identify and pull out groups, both for looking for things like prognosis and for identifying groups who deserve more research in terms of translational aspects. And as a sneak peek, we've been looking at some radiological risk stratification, which I've been picking up recently, and we've identified, kind of validated some of the things that we already know, that patients who've got lymph node disease or a small number of lesions do much better. The patients who've got a large number of lesions, or particularly patients who've got peritoneal or bone lesions. We're a large team here in Edinburgh. I'd like to thank everybody, particularly Sally Clive, who couldn't speak today. I think she's climbing somewhere. But just thank you everyone, to all our patients, and thank you very much for your time, everybody.
Great. Thank you so much for that excellent talk, Mark. And thank you everyone for giving your time today to deliver these presentations. We just have time probably for one question for each of the presenters, if that's okay. I'll go in reverse order, seeing as Mark Stairs has just finished talking. So a question's come in about, obviously you mentioned your group has a very a lot of the group has a poor prognosis, and some of these patients get best supportive care only. Is there something that we can do for those patients, and has there been any improvements already for those patients that perhaps are not well enough to go on to further treatment options?
Yeah, so only about a third of our patients with a confirmed CUP actually end up having any form of systemic anti-cancer therapy. I think there's two key things that have come out from our kind of looking at our clinical research, is that a large proportion of our patients get radiotherapy for symptomatic control. And here the CUP service is run by medical oncologists who don't necessarily have access very easily to the radiation oncologists all the time. And so it's bringing those into the fold has been more interesting. And the second thing is having very close links to the palliative care teams. And it's telling that both from a clinical point of view, but also from our research point of view, that we've had collaborations with palliative care experts.
Great, thanks, Mark. And then going on to Mark Lithgow.
Hakeem's asked the question.
Yes, yeah. So basically, do you think there's a genetic basis or a genomic signature on whether or why certain bacteria is more prevalent in certain tumours from the gut than, for example, their primary or metastatic sites? And if so, can you leverage this as a biomarker or therapy?
Yeah, no, absolutely. So a really interesting question. Thanks, Hakeem. So yeah, we do think definitely there's probably going to be some genetic predisposition to specific strains of bacteria. I think it's really interesting that when we looked within the tumour microenvironment, we've actually been able to identify bacteria within immune cells. Now, if you look anywhere else in the body, bacteria don't normally occur in immune cells. And we believe that somehow the tumour environment is sort of almost priming the sort of genomic apparatus of the immune cells to to provide sort of bacteria this niche for sort of colonization. One of the potential spin-off projects that we're actually going to look at, maybe to look at potentially primary samples and then look at the intratumoral environment of metastasis and compare the two to see if there's some sort of shift in terms of the intratumoral microbiome. But absolutely, it's a really fascinating question, and I'm not sure I have an answer for you at the moment, but this is absolutely something we're going to explore, and something that may interest you is that we are absolutely thinking about trying to link in with some clinical trials at the moment. So we've been in discussions with Dr. Wassam maybe for PEMCUP, but absolutely Capisco. I believe the tumour samples are quite small that you have in Capisco though. So, but if you're happy to have an offline chat, I'd be very happy to have a chat.
I just want to find record. I just wondered whether you meant that you would biopsy normal gut and then tumor gut and then or whatever you want to do. So would you do a kind of matched gene signature within 10 centimeters of the area that you of interest?
Yeah, I mean, I think absolutely. I think if we could think about that maybe for a sort of a later project for sort of confirmation. But I think at the moment, unfortunately, those samples are unlikely to be available. But I think luckily there is quite a well sort of established sort of literature of the normal sort of microbiome composition. So we were potentially just looking to really sort of compare to that and the adjacent epithelial tissues.
Thanks.
Great, thank you, Mark. And then a question for Alicia. So obviously you mentioned the importance of the lack of tissue and the fact that we can do a lot of testing now in the blood. Do you think in the future that we could just potentially be doing blood tests on cut patients rather than any further invasive tissue biopsies?
Well, I don't think liquid biopsies will completely usurp the need for a diagnostic biopsy. But what we do know from the work that we've done is that a blood test is standard of care and can happen really early on. And actually, cut patients end up having lots and lots of immunohistochemistry stains that adds a lot of time to their diagnosis. Whereas having a blood test, even though it would maybe take 2 weeks to get that molecular profiling back, that's quite quick compared to some of the biopsy results. Again, I think it would be an adjunct rather than completely take away the need for a tissue biopsy. That is still important for some patients.
Great, thanks, Alicia. And then I guess finally a question for both Kai-Keen and John. Kai-Keen, you mentioned the NCRI group. I guess what are the next steps for that group, and what are the kind of exciting projects going forward for the NCRI group that you see happening in the UK?
Yeah, so it's a relatively nascent group. You helped set it up with me 2 years ago, and we've kind of been live for about a year. COVID certainly hasn't helped collaboration, but as you see, with Alicia and Mark, we're already getting some quite good kind of outputs. I think from a general kind of overriding perspective, I think we talked about cup comp. I think in some ways, we do actually have to set up this kind of biobank, to at least start having a bank of tissue that we can ask questions. And now we try to do that with Cup 1 and all those things. But I do think with this new generation of investigators, and this is the platform, of course, to go around the world with all the stuff going in Australia and in Europe and in America, we should do it. So I suppose my overriding thing is that we are hopefully today prove that in the UK is hopefully the forefront of cut research. But we've got a lot way to go, and we can't do everything by ourselves. And what I would hope is that that there's an open platform for people to come to us and shoot ideas off and collaborate that way. So there's a lot of things that we can talk about that we already have done, Natalie, but I really think this is the platform for the younger researchers to say, look, we have some really great ideas you haven't thought about. And this is now our kind of platform to springboard them into whatever research we think is the right thing for our patients.
Great, thanks, Kai-Keen. And I guess final word to John, and obviously I know you're involved with the NCRI group as well, but the whole point of these seminars is to try and bring together all the different teams doing cut research throughout the world. And so how important is that, and why do we need to do that, John?
Well, it's very important. And we gain so much experience from researchers from around the world. And we've had over the years international CUP conferences in London, but of course we haven't been able to have one since 2019. And so this has been a really good experience in terms of sharing information amongst researchers. If I might add one point in relation to something that Mark Stairs said is I do think one thing that we sometimes tend to neglect, and from a patient advocate point of view, it would be good to see improvement within hospital trusts is better integration between palliative care teams and oncology teams. It's terribly important. And given my starting point of the mortality data, one can see how important that is.
Yes, absolutely, and a very important point to end on. So with that, I would like to just thank all of the speakers for today's session. Tomorrow's session, the next in a series of webinars, will be an update on the Capisco trial, so extremely exciting. The details are on the website, so worldcupawareness.org. And if you obviously want to watch live, you can register for that. And if not, there'll be access on the website to all of these seminars soon. So thank you all for listening, and have a good day.